Thank you very much, Luke. Rick, actually, you made my presentation to make it easier to understandable. When we started to think about the implementation science, we knew nothing. And it was like 2017. And we actually, that came the idea of implementation of vending machines is tightly connected with the Global Fund, who is the only ultimate, the only exclusive, I would say, donor helping us to fund HIV prevention services among people who use drugs. And understanding is that the Global Fund is phasing out from the country, and we are in transition from the donor fund to state funding, but somehow not everything goes well when it's connected with the injection drug use, because there is a lot of policy related issues, and to some extent it's really tied with willingness to fund, for example, needle and syringe programs. So the idea of syringe vending machines came, implementation of this intervention was probably the sole solution we are thinking of, that probably funding will not be enough for continuation of syringe and needle programs. And these vending machines will help to some extent to cover these HIV prevention programs and to have kind of continuation. So here came the donor, which is 5% initiative. This is the state fund coming from the France. And our partners in this endeavor were National Center for Disease Control and Public Health and Georgian Harm Reduction Network, who is the main provider of needle and syringe programs in this country. We started collaboration with these two institutions, so that started thinking about how to implement these syringe vending machines in Georgia. What we know from literature is that these vending machines are really effective to deliver HIV prevention services to people who inject drugs in the cost-effective way, because they are cheap and they work, they can deliver these services uninterrupted, 24 hours per every day, per 7 day per week access they give to HIV prevention packages. Also, what we know from literature is that these vending machines are helping to reach the most hidden groups, most hidden populations of people who inject drugs, and they're improving the geographic coverage. And what we know from literature is is that this intervention is cost effective. And we said, let's try. But we knew nothing about implementation science and etc. But what we did is to get to know with what is known well, started searching literature about implementation science and etc. And we thought about the framework, which is nicely was explained this morning about the REAIM framework. And this presentation is about how we applied the REAIM framework to implement these syringe vending machines. So the last one, you probably wonder why we have it in red. These vending machines do not replace traditional needle and syringe programs. They are complementary. I guess Lynn is already already guessing why we have it in red, because it's actually appeared challenging to make believe service providers that vending machines do not replace their work of outreach workers, social workers, which became major challenge for us. So let me describe step by step. Our aim was to implement and evaluate effectiveness and the process outcomes of introduction of syringe vending machines in Tbilisi. So the first stage was formative stage. We used a bundle of approaches to understand what would be the acceptability of vending machines if they will be implemented in the city, how that will be accepted by clients of needle and syringe programs, how they will be accepted by the service providers as well. So the most highly endorsed features, what we learned from our formative stage was like uninterrupted free access to sterile injection equipment is the key for this implementation of this intervention, and the privacy when they're going to vending machines and taking whatever they would like appear to have much higher kind of trust to compare with the, for example, the pharmacy when they are going to pharmacy and ordering some sort of syringes and they are in line with others, and actually everybody already knows why you are buying certain syringes when you are ordering that. So the anonymity also guaranteed using these vending machines. And we actually also did respondent-driven sampling of those people who inject drugs who are not involved in HIV prevention services, so that asking them if there is vending machine in the city, are you willing to use them? Would you use them? So we got high rate of almost 100% of them answered that yes, this is such a nice idea, having vending machines in the city. And the bottom line is that acceptability of these vending machines was quite high. And also asking that if there will be HIV self-test kits available through these vending machines, will you be willing to use them? And of course, here again, acceptability of these self-testing HIV kits also was high. Also that actually was high among those people who inject drugs who've never been tested, because majority of these 150 people who inject drugs, we are not tested. Like, I guess it was 60%. We are not tested on HIV. So this is a snapshot of our methodology. Step 2, which doesn't like. Actually, we didn't know that it will cause too much troubles. If you ask me, would I go for this methodology again? I probably reconsider. so the methodology is kind of we have 4 service centers, for needle and syringe service centers in Tbilisi, and we wanted to affiliate each vending machine with each service provider. So we started this project, the formative stage, in April 2018. And this period, this phase of the study, devoted to the formative study, we discussed the model, how it will work, what it should like, because we even didn't know what's the vending machine will be. We will be implementing in Tbilisi. So we discussed a lot with service providers, with clients, with stakeholders, with health experts, and that took us a lot, by the way, almost a year. And we already, by July 2019, we are ready to implement first 2 vending machines, which were affiliated with the one service center. The service centers were selected randomly. What we did is that we prepared team of these service providers, how to we taught them how they need to talk with the clients, how they need to explain what's this service about, and also the actually the vending machine itself was kind of our invention. I will explain later what's that. And we expected some difficulties with using those new machines. And we try to evaluate everything, whatever could be evaluated. So step by step, we implemented two new vending machines in the city in two different places, so that those new two were affiliated with the new service provider. And the data that we collected before the implementation, it's indicated as C. This serves as a control data, control of themselves, of those service providers who are in the study. So that, for example, the first site, during the first 3 months, we collected control data, and then our implementation phase data, so that you see that some of centers gained quite a lot of experience of having syringe vending machines. And we applied the REAIM framework to assess the outcomes across 4 REAIM domains that explained this morning by Luke. So reach, effectiveness at providing syringe access, adoption, and implementation. So what we initially were thinking about providing tokens to clients so that they have these tokens to get access to these vending machines and get the HIV prevention kits. But as we've heard a lot about implementation science, not everything goes in the way you are planning, because you need to adopt the local context. And at some point, we came across some legal issues, some political context. So we decided to have the specific cards so that each client of syringe and needle programs will have the card that will give them access to a syringe vending machine. So in this way, we avoid the use of machines by non-eligible persons, because all these materials were delivered to them free of charge, supported by the Global Fund. So the stakeholders were worried about, how about the kids who will see the vending machine and maybe they will put their money and get some syringes? Is that okay or not? And we thought what's the best fit of the model of delivery of this service? Because not only the vending machine is very important, but also the model of the service, mode of the service delivery. So we call it Sigma. It's a Georgian abbreviation, Sigma Plastic Cards, which were distributed to service providers to distribute among their clients. And we actually developed specific software for tracking these plastic cards, so that we knew in real time which plastic card goes to which service syringe vending machine and gets what kind of packages. And hardware which we used, it's better to, if I explain in the example of vending machine, this is our vending machine. It's actually, if you see this vending machine, it's always near to pharmacy, PSP, because they are providing electricity for our machines. And they were quite generous to help us in this endeavor. So this is the just like usual vending machine. We ordered it from Spain. This is made in Spain, and this is just Coca-Cola vending machine, probably. And what we did is we absolutely modified its mode of work. We installed touchscreen. we installed RFID reader card, and we made these vending machines smart. Because we installed small computer, it's called Raspberry Pi, with our hardware, with our software, so that all these packages, what you see bottom on these three shelves, are specifically packed for people who inject drugs. These are provided by the syringe and needle programs. And the upper two shelves, we decided, according to our formative study, uh, to be available for everybody, for everyone who comes to vending machines. They can buy whatever they see on the first two upper shelves. And we decided to cover the rest of the shelves because they are not for public, not for everyone, and there is no need to display. In this way, we somehow tried to disguise all these prevention kind of aims, because what we got from formative stage is that if these machines will be used by people who inject drugs, it will be labeled as junkies machine, and nobody will go there to get HIV prevention kits. Therefore, we needed something to think about how to make it acceptable for public as well, because we did some survey with among neighborhood, and they were not so kind of, yeah, they were resistant to the idea that here is a machine and it will be used by junkies. No, I'm not okay to having such machine in my neighborhood. And therefore we came up with the idea to cover the rest of the shelves with the poster. Poster just, it's about immunization calendar and about Hep C elimination program, which was implemented by the state. That provides details about that. And if you come up with this vending machine, it displays by default the prices of those products which are presented on the first two shelves. And here are kind of some such a petty things which can be bought by anyone, and they are not kind of harmful products. So if you are touching screen, you are getting the price and that's it. But if you have the Sigma card, which is the just plastic card programmed so that our RFID card can read it, if you touch it here, then hidden menu will pop up that displays those products which are available for people who inject drugs. And just choosing it from the menu, you are getting the product loaded in this kind of box, and you are getting it. And every time you need to touch and select the one product by one, you are getting from the selecting of this from this menu. And also we had an idea to attract other people who inject drugs who are not these service clients, so that they will try for a 1 month the card. And if they will like, they need to go to service centers to reactivate their cards. And that means that they are becoming clients of the needle and syringe programs. And we asked people who inject drugs who are already clients of these services to distribute these cards. But somehow this secondary kind of, we call it baby cards, they didn't went well, while we thought it should go well, because we set up some limits of taking the packages out of these machines in order to avoid, some excessive use of these machines. Initially, we didn't thought about that, but when we saw that one plastic card vended like 14 pregnancy test kits, so that was kind of weird. Why this person needs? And when we approached this person and asked, the answer was like, maybe tomorrow it will not be available, and why not? Let's have it. And therefore, we worked with service providers and came up with the limits. What is the ceiling of the packages we need to set up for the packages. So these are the list of packages provided by the vending machines, just usual HIV prevention kits, opioid users package, package for stimulant users, overdose prevention package with the naloxone, male condoms, pregnancy test kits, and female condoms. By the way, female condoms were kind of new product for Georgia because it's not available in pharmacy in the country, I would say. So what's happened? What we saw is that starting from implementation first to machines, the utilization of these machines rised step by step, steadily. And here, of course, COVID comes. And it ruined everything, whatever that we were counting on, because what we saw while analyzing all the data is like 52% of transactions occurred during non-working hours and holidays. But COVID, that's because of the curfew was introduced, everything ruined. We couldn't show the effectiveness in this regard. So, but what was the solution is that to get kind of specific permission to load the machines when they are empty, and we got right to move around city during curfew. But this is not about just loading. The machine should be utilized, should be used by the clients. So results, having in mind the REAIM methodology, we measured the reach, and the reach measured through how many cards were distributed and how many out of distributed cards used by the clients. So we gave access to 1,846 SVM cards to people who inject drugs, and SVM reached 8% of the target population. Expectations on reaching out of service PVID not met. And again, here we blame COVID because it really was main interrupter. We had disruption in provision of materials as well, and sometimes our vending machines were just empty. So as of effectiveness at providing syringe access, SVMs dispensed 14% of all syringes distributed by HIV prevention services within city. Using SVM was associated with people who inject drugs receiving more sterile syringes from HIV prevention outlets. And as of adoption, all HIV prevention sites, which we are 5, invited to implement SVM agreed to participate. 61% of PWIDs who received SVM access cards used SVM at least once. And women and young people who inject drugs, we are more likely to use SVM compared to others. And as of the implementation domain, some sites' adherence of the outreach staff to the operational protocol was suboptimal. And actually here was the fear of social workers, outreach workers, that SVMs will replace their work and they will lose work. And we put lots of effort to make them aware that there is no replacement of their work, and SVM cannot work as human. So, but it took time really to accept this service by Georgian service providers. And here we have kind of average number of syringes monthly received by PWIDs who use SVM, which is 130. And average number of syringes monthly received by PWIDs who didn't use SVM, it was 1,000. And this Yes, sorry, number of participants whose data were analyzed, sorry. And before SVMs were installed, the average number of syringes were 31, but as far as SVM installed, it's almost not doubled, but pretty much doubled. Uh, yeah, and difference was statistically significant between these the receiving of these syringes. So transactions by types of packages, it shows that opioids were more and stimulants popular among our clients, and daily transactions by SVM location. What we understood from this is that location matters, where it is installed, and uh, also those who are living around, because it's appeared that those who are living around, they are using more frequently these SVMs. And also, when we, that was actually piloted when we got first bunch of HIV self-tests. We did nothing regarding just making aware of the clients about HIV self-test. We just loaded, and in menu appeared HIV self-test. Exactly within that day, the first order we had already in transaction the first order of HIV self-test. And on a screen, when, for example, client gets HIV self-test and comes next time to get some other packages, the screen displays the message, you got HIV self-test, have you tested it, have you used it, and etc. And we got pretty much good kind of feedback. And you see here that this brief questionnaire, like questionnaire completed by like 74% of those who vended HIV self-test were willing to respond to our questions. And we also provided through web portal the access to the information on HIV prevention and all the services available for them in order to switch from screening to make a linkage with the HIV treatment centers. We did economic evaluation as well, but I'm running out of time. So what I'm saying is that we used all the, we actually utilized all the components of implementation science. Even costing has been conducted. But what we've struggled with is step-wedge design analysis. that's why I would reconsider next time if I will go. So a few words about limitations of this study is that SVMs were installed only in the capital city, so we are not able to talk about generalizability. Observed stockouts may have had negative influence on generating the trust of people who inject drugs for SVM services. Measuring fidelity was challenged because we were not able to calculate those people who are coming to service needle and syringe programs asking for these cards directly, because these were was identified as an additional burden for service providers to keep records and etc. So due to deliberate contamination, cluster-based data could not be analyzed because every card holder could use machine which is installed throughout the city. But they we are centrally connected so that the limits set was common for each machine. For example, if I am able only download 2 packages, it doesn't matter I'm getting that from 1 machine or 2 machines, 2 is 2, and that's it. So yes, as of conclusion, SVMs were acceptable. They reached a notable share of potential beneficiaries and were actively utilized by them. SVMs improve access to HIV prevention kits because they receive more syringes compared to receiving syringes from HIV service centers. They are economically feasible and potentially can be used to deliver various services to different groups. because at some point we are thinking maybe PrEP medications could be delivered from these vending machines. And future research is needed to examine how to motivate field staff to better promote SVMs among their clients, because at some point we saw the drop of the distribution of cards, and what specific strategies can facilitate engagement of PWIDs is very important, and that also needs future research. That's it. Sorry, I exceeded my time.
Thank you, Irma.